go through all things fertility with you on a weekly basis. I am your host, Dr. Rahi Victory. I'm a fertility specialist, bringing you the latest and greatest in all things fertility. And due to requests from all of our audience, we're going to start branching out a little bit. So tonight we're going to be touching on endometriosis, which is always a hot button topic around here, both for patients that are suffering with endo and for patients that are suffering from endo and also have fertility issues. So yeah, we're going to review all of that and make sure that you guys get a good understanding of what's going on. The study's really great, and it's also Ontario, Canada based, so I'm excited about that as well. Do we have sound? I want to make sure that everybody can hear us. Make sure you click that like, comment, and subscribe button up there. We want to make sure that you join us, and thank you to all of our viewers. Our show has grown by leaps and bounds since we first started. And we have had our biggest audiences over the last few weeks. So we're really excited to be with you back again. You can follow us on any of our multiple platforms. YouTube is always a big draw. Instagram seems to be growing quite rapidly, Facebook, and even on Twitter. So thank you for joining us. Okay, so let's talk about this particular study. This is a study called the Long-Term Follow-Up of Endometriosis Surgery in Ontario, a population-based cohort study. So Ontario has the advantage of having all healthcare provided through a socialized medical system. And so some data is provincially captured by looking at billing codes. So you can figure out what patients were seen for what services, and then what other services they received and how long it took till they got that, and so on. So everything's done by codes, and you can figure out what patients had or not. And then it's all entered based on diagnostic codes as well. So clearly, if the patient had endometriosis, their surgery would be coded for endo, and then the type of surgery would be listed. Why is this important? Well, one of the major issues we always face with patients that have endometriosis is, what do I do to treat it? And there are sort of four different options. I'll go through those with you in a moment. 2, what happens if I treat it? What are the outcomes of that treatment? And then 3, am I going to need other treatment if I pick A, B, and or C, in terms of what other therapies or treatments will be necessary on top of what I'm already choosing to do? And then the last issue, of course, is fertility. So do any of these seem to help or change the responsiveness or the likelihood of success with infertility? So we want to kind of go through that with you tonight and review all of that with you. And of course, I'm sure many of you have questions. We do answer all of your questions live after this segment. So make sure you start asking your questions at any time, and we'll get to those as we go. Okay, so the study here definitely looked at a huge population of patients, 84,885 women collected in the database between 2002 and 2018. So what sort of treatments are available? Well, you can do nothing. Not great treatment, but not everybody necessarily needs to do something when they have a couple of flecks of endo. There are some patients where I get in there and I find only one little tiny spot. We, of course, always treat, but arguably if it's just one tiny spot, they're not in debilitating pain or some kind of problem like that, you don't necessarily need to do extensive surgery. 2, you can try natural approaches. There are a host of various natural antioxidant-based approaches to treatment of endometriosis, which can actually be beneficial. So coenzyme Q10, NAC, curcumin or turmeric powder. And then as I was preparing for this, I found out that there was a randomized controlled trial of using modest doses of vitamin C and E, which also helped reduce pain. So there are some evidence-based, logical, natural approaches that people can use. And for those of you that are interested, we do have a video on our YouTube channel on natural treatments for endometriosis. So maybe Tara can find that and post that for us on this video. But just click on that button and you'll be able to watch that video later on as well. So huge population here. And what these patients all had was surgery. So these are all the women that have said, you know what, I'm debilitated from my pain. or discomfort or my fertility, I need surgical evaluation to deal with this. So from the whole group, the percentages were that 3.2% underwent diagnostic laparoscopy, 25.4% had minor conservative surgery. So this would be like burning the endo or removing the endo for small little bits. 33.6% had major conservative surgery, but with ovarian preservation, meaning they did not remove the ovaries. And then 2.5% had major conservative without ovarian preservation, meaning they did have their ovaries removed. And 25.5% had a hysterectomy but kept the ovaries. And finally, 9.9% had everything removed, their uterus, their ovaries, their tubes, in order to manage the pain. So keep in mind, for those of you that are regulars on the show and are always watching us for infertility, this is not purely based on infertility. This applies to all women. And so it's a more generalizable study, something that's really critical for everyone to realize. So we're going to flip over to the first table. So remember, this is a nice data set because it's coming retrospectively from a huge governmental database. This is not something anybody's messed with in any way or tampered with. So we're going to go through table 1, and I'll go through some of the details there with you. So average age around the mid-30s for the women that had conservative surgeries where they weren't removing the uterus. So, diagnostic laparoscopy, 35, minor surgery, 32.8, and then major without removing the ovaries was 35.6. When you get into the group that's deciding to remove the ovaries, you're obviously looking at an older age group, and same thing for the uterus as well. So you're looking at 43.9 for major surgery without removing with removing the ovaries. Hysterectomy was 41.8 when they preserved the ovaries. That's what BSO stands for, bilateral salpingo-oophorectomy, meaning we're taking out both sides of the tubes, which is the salpingo, and the ovaries, which is the oophorectomy. And then hysterectomy with the BSO was about 44.5 for the average age. Reasonable number of these women had never had children before. So nulliparity means you've never had a baby before. So 66.9% in the diagnostic laparoscopy group, 66.1 in the minor, 62.5 in the group with major surgery but preserving the ovaries. So quite a high number in that laparoscopic sort of approach to thing, or minor or major surgeries where they were preserving the ovaries. And then 54.5 in the major group that had removed the ovaries. And then for the group that had the hysterectomy, 36.5% had never had a child before, and 50.5% in the group that also opted to have the ovaries removed. So obviously that's a group that's going to be quite debilitated, and they're willing to trade off, obviously, the hopes of having a family for the fact that they just need pain relief or for the endo to cease. And, obviously this can be a very devastating and terrible disease for a lot of patients. So some people will have to make that decision and on balance decide to opt for something that is less significant and less impactful. And others will opt for something that is much more significant and more impactful. I don't think the income is really of anyone's interest here. And so the numbers that I do want to share with you gave birth before surgery. So roughly around 33% to 37% in that first three groups, so the diagnostic, the minor, and the major with ovarian preservation. Again, once you start getting into the more major where you're losing the ovary, about half or around half had previously had a birth. So 45.5 in the group that had major surgery where they removed the ovaries, but not a hysterectomy. 63.5 in the group that had the uterus removed, but not the ovaries. 49.5% in the group that had everything removed. Infertility consult prior to surgery. So this is really important demographic information. How many of these women actually sought out finding out what happened with their fertility or what was going on with their fertility. So quite a number. In the minor group, 44.2%. Now, it's kind of interesting for me that 44.2% of these patients underwent diagnostic laparoscopy, where someone actually looked inside and then didn't do anything, because all of these patients had endo. So this is kind of crazy to have surgery for endo where you look and then don't do anything. That makes no sense. 36.3% in the minor group, 31% in the major group, but with ovarian preservation. 8.6% of the group that had their ovaries removed with major surgery had a fertility consult ahead of time. 6.1% in the hysterectomy group, 6.6% in the other group. So kind of interesting that once they moved into hysterectomy, some of these patients had not had fertility consults previously. So I'm not quite sure why. It kind of made me scratch my head when I read that one. Emergency visits, thankfully, relatively low. And then many of these patients, obviously 60 to 70% of them, had seen a physician previously for pain before they underwent the surgery, which obviously makes sense because not everyone's running into an operating room just because they have a painful pelvis or painful period. So we're going to go to table 2. So these are the postoperative outcomes from 30 days after the index surgery. So the nice thing about this study is they were able to follow these women for anywhere from about up to 14 years or so. So you can see that the average age of follow-up was like 9 to 11 years. So pretty robust time. So the type of surgery that some of these people had, so a majority had nothing, anywhere from about 70% all the way up to, obviously the ones that are having hysterectomy are not having repeat surgeries. But for the ones that did have something done, you can see there, like if they had diagnostic laparoscopy before, less than 1% underwent the same again, but up to 11% had major surgery done subsequently, and 8.6% went on to have a hysterectomy. For those that had more minor approaches to things, about 0.5% had a diagnostic look again, which again makes no sense. Why would you do that? But 7.5% to 8% had either minor or major surgeries. 9.4% went on to have a hysterectomy. So keep in mind, these are people that had surgery before, had treatment in a minor fashion, so zapping endo, and then about 7 to 10% of them are going back to have additional surgery done at some point in the next 11 years on average. As you get into more major surgeries, you can see that the rate goes up until you get into the hysterectomy cases, where obviously no one's going back in after you've had a hysterectomy because there's not a lot we can do. Table 3 jumps into some issues for pain and repeat surgeries within the first year. So this is super important. You've now had your surgery, any one of those categories that we've looked at. What's the chance you're going to continue to have pain and require either a hospital visit or a physician visit or a repeat surgery? So in the diagnostic laparoscopy group, 15.8% saw their physician at least once, 15.5% more than 2 times just within a year after their initial surgery. Makes sense because, obviously those people did not get any treatment. They just had diagnostic testing at the surgery. So they're going to continue having pain, probably have follow-up. Interestingly, almost 70% of them didn't go back for any kind of evaluation or complaint, even though they didn't have anything done. So kind of a unique finding. The ones with minor surgery, again, almost 2/3 have nothing done, but 17.6% went in once and 17.5% went in more than twice. For those that had major surgery but preserved the ovaries, same thing, you're looking at that 15% mark. For the ones that also had the ovaries out, even though they removed their ovaries, 17% went in at least once, 14.7% went in more than once, meaning, two or more times within the first year alone for pain. So simply removing your ovaries is not a guarantee. For the group that even had hysterectomy, even those patients still had to go back for pain with roughly the same numbers, 16.3% if you left the ovaries, 13.1 if you took, if you left the ovaries, and that group went back more than 2 times. And again, in the group that had everything removed, the uterus, the tubes, the ovaries, you're still looking at that 15% and 13%, almost 14% mark for patients that actually need to go back to their physician. In terms of the number that required surgery, emergency department visits, the numbers vary, but thankfully there weren't a ton of emergency department visits, but they are hovering on average around that 3 to 6% mark. So 3 to 6% of patients actually presented to emerge for pain within the first year after they had had surgery. Why is this critical? Because if you've ever been to a Canadian emergency department, it takes forever to get through. And so unless you have an easy access in, which no one has, it's extremely difficult to get somebody through the emerge. So it's a bit of a nightmare going through the emergency department, no matter where you are. Readmission to the hospital for pain is thankfully very low. Interestingly, any repeat surgery, you can see there, the ones with diagnostic had the highest incidence, then minor had the next highest, then major had the next, and then so on. So keep in mind, 14.5% of people that had diagnostic laparoscopy required an additional surgery, which makes sense because they should have had it when they had the original one, didn't get the right thing done. But even 8.5% of the ones that had minor surgery actually had to go back within the first year for another procedure. That's kind of crazy. About 1.8 to 4.4% actually had a hysterectomy within the first year after their initial diagnosis, even though some of these people were getting major surgery where they were preserving the ovaries. The final one to share with you is number 4, table 4, I should say. We've kind of gone over this, but this extends it out to the second postoperative year. So you can see the longer we go, the higher the number of patients that needed to go back for pain visits. So instead of the 13s and 15s, now you're looking at 18, 19, 20, and then for more than 2 visits, 25s, 29s, 24s. So very substantial numbers. Even in the group that had a hysterectomy, 22% of patients ended up going back to their physician more than 2 times within the first 2 years. So huge numbers. So getting a hyst does not necessarily mean you're going to be pain-free. And when I'm doing surgery for my patients, and I still perform hysterectomies for my patients with debilitating pain, I warn all of them, there is no guarantee when it comes to pain. And that's super important for people to know, because everybody thinks, oh, I'm going to get rid of my uterus, I'm cured now, I'm going to be fine. The reality is, even if you remove your uterus, even if you remove your ovaries, we cannot guarantee you your pain will be resolved. And some women even get worse, especially if there's scarring or adhesions. So very important to remember. Same thing when you look at the emerge visits, which we just reviewed. Any repeat surgery starts to drastically increase. So again, 18.8% for the ones with diagnostic, 13% for the ones that had minor, still 8.2% within 2 years that had to have some kind of treatment done, even after major surgery the first time. So within 2 years later, they're going back for another procedure. The good news, somewhere between 0.4 to a high of 5.9% went on to have a hyst within the first 2 years. So not everybody is being forced into that final and often kind of definitive movement or choice. And then childbirth was, obviously from the fertility perspective, something that a lot of you want to know. So how many of these women went on within the first 2 years to have children? And the answer is 15.8% that had the diagnostic laparoscopy, 16% for the ones that were minor, 11.7% for the ones that had major surgery, and then only 0.6% for the ones where they actually had the ovaries removed. So obviously those are people that are going to be forced to go on and do egg donation. So it's a much smaller population. Not shown in this table, but included in the write-up, is the fact that up to 5 years, which they don't show here, the numbers got much better. So 28.5% of patients who had diagnostic had a baby, 29.4% of the ones with minor, 20.7% of the ones that had major surgery but preserved their ovaries. Obviously, no one's having a baby if they've had their uterus removed. So it really just leaves you with that small category of women who have had their ovaries removed but have their uterus and are going on to have donors, and donor procedures. So the key with all of this is the following. Number one, getting endometriosis surgery does not necessarily mean that you are in the clear. You may continue to have pain, hospital visits, physician visits, causes for you to have pain will continue. In many, many cases, around the fifth of cases, a fourth of cases, are going to end up needing additional treatment or additional visits. Number two, there are a number of cases where they end up going from the original surgery to definitive surgery, which is removing the uterus and then potentially removing the ovaries as well. And that's really important to know, because a lot of people feel that if they do a laparoscopy, they're now fine. The reality is you may not be fine. We may do a very detailed procedure, but you could continue to have pain. And the last thing to know is that there is quite a bit of hope that once you've had this surgery, you can go on to have childbirth, because a reasonable number of these patients are achieving success. But yes, it's true, many of them will go on to seek the assistance of a fertility specialist. And that's important for people to know, because some of these patients will need fertility assistance even after the surgery. Getting surgery does not mean you're free and clear of needing a fertility specialist or needing insemination or needing IVF. You may still need those things. They can be very, very important. So I just wanted you guys to be able to have that data at hand. I think it's really important for people to understand surgery is a very useful tool, but it is not always going to be curative. Remember, we can't see every single spot of endometriosis, so it can be very difficult to remove it. I do support taking a natural approach, a holistic approach to this. I very frequently will recommend patients have surgery, in particular as part of their fertility journey, because reducing the inflammation from endo can make a very big difference in terms of your treatment. But there are also great medical options that are available to you, and those should also be explored. Not everybody is a great candidate for surgical therapy, nor is it necessary in all cases. And not all medicines are necessarily mandatory. Like I said, you can approach this from a natural perspective as well. So make sure you click that like button. We want to hear your comments, so let us know what you thought, and punch that subscribe button when you get a chance, and show us to your friends. We want other people that you know that are suffering with endo or pelvic pain to know about this, because we think it's really, really important everybody know what to expect when they're considering surgery. We're going to take your questions live now. So thanks for joining us for that segment.